Scapular movement still matters. It is a fundamental part of how the shoulder works, but it is probably not the clean diagnostic clue many of us were taught it was. For a long time, shoulder assessment was often taught as if we could look at the scapula, spot an abnormal pattern, and then link that pretty directly to pain. But scapular motion is naturally variable. People move differently. Arm dominance matters, load matters, task matters, fatigue matters, and the same person may not move exactly the same way every time. So the risk is that we see a bit of winging, shrugging, or early scapular motion and immediately call it dysfunctional. But variation is not the same as pathology. That does not mean we ignore the scapula. It means we stop treating scapular position, rhythm, or movement pattern as a standalone diagnosis. A more useful clinical question is, does changing scapular movement actually change this person's pain, strength, range, confidence, or function? For example, if a scapular assistance or repositioning strategy improves symptoms or performance, that may be clinically useful. But if the scapula looks a bit different and changing it does not alter anything meaningful, be careful building the whole rehab plan around it. The scapula is part of the story. It is not always the villain. So when you assess shoulder pain, do not just ask, does this scapula look abnormal? Ask, does this movement finding matter for this person in this task under this load? That is a much better clinical reasoning question. Save this if you assess shoulder pain, and follow for more practical shoulder assessment and rehab content for clinicians.